medical education online. And it's free.
This lecture is about addiction. We're going to spend the first half of the lecture talking about some vocabulary and definitions, as well as the pathophysiology of addiction that is going to help you deal with patients on the ward and in your clinical practice. The second half of this lecture is going to be what you need to know for the USMLE. That is the acute intoxication of each drug and their withdrawal symptoms. You need to be able to identify acute intoxication and withdrawal for your test, but it's going to be much harder for you to deal with patients in real life who have addiction if you don't understand where they're coming from. Let's start off with some definitions. Abuse and dependence. Usually these terms are defined by examples, but I'll give you a punchline up front. Abuse is using a drug or medication or alcohol in any other way than it should be used. Very vague, I know, but that's the actual definition of abuse. Dependence is needing more to feel the same thing. Your body gets used to it, and now you need more of it. So examples of abuse are patients who have legal troubles because of their use. They put themselves in risky situations. Going into bad neighborhoods or having sex for drugs. They have a failure to fulfill their responsibilities. And they continue to use despite these problems. That is, they know what they're doing is bad for them because they're having sex for drugs and getting arrested for DUIs or public drunkenness. They're not being able to sustain their families or their jobs if they continue to use. That is abuse. Dependence is having your body getting used to it. Examples of dependence are things like tolerance. You can handle more and you need more for the same effect. Likewise is withdrawal. If you stop using, you have physical signs and symptoms that develop as the drug leaves your body. People with dependence will also find themselves in isolation because either people don't want to be around them or they only want to be around people who use. They'll spend too much time trying to get it. And they'll sometimes take too much. That is, there is risk for overdose. So with all of these problems, legal issues, failure to fill responsibilities, needing more just to get the same high, why do people use drugs? And that is asking the question, what is the pathology of addiction? Now, not everyone who abuses drugs or gets dependent on drugs is an addict. Some people just like to party. But the person who is an addict has a genetic predisposition to the disease. This is how it works. This is, say, happiness. When a normal person goes through life, they're generally neither happy nor sad. They're sort of neutral in the middle. And then they'll party, have a good time on Saturday night, wake up on Sunday morning hungover, and then get back to living their normal life. And they kind of stay there in the middle. They have some ups and downs based on whatever's going on in their life. And then they go out again. Have a good time on Saturday night, get hungover on Sunday morning, and go back to living their life. The idea is that the party is fun, the hangover sucks, but they recover their baseline function. This is someone who is normal. The pathology of addiction is something like this. Up until that first hit of that drug or the first taste of alcohol, The addict is normal for all intents and purposes. But on that first party, the high is really high. The good is really good. And life without the drug, even after the hangover, is not quite the same. And so experiencing that awesome high, that really high high, the addict wants to feel that again. And because they are now unhappy without the drug, they use it again. And that high is really good, but never gets them back up to the level of that first high. The hangover is bad, and then they're even more unhappy. So what happens is that in an attempt to chase that very high high, that first time dose, the addict is going to continue to use. But they're going to continue to use so that they can feel normal. This is not really going to help you on your USMLE, but what it will do is help you deal with patients in a group setting. Or if you have a patient on your service or on your test who is an addict and needs pain control, the answer in the test, by the way, is give them pain control, you can have that discussion with them. Because if they are clean, then they have moved their baseline back to normal without the drug. And if they start using again, they may end up back down here. So this hopefully will help you understand the addict's mentality, understand an addict's disease, and treat them better as your patients. Let's transition away from the things you need to know how to take care of somebody and start talking about the acute signs of intoxication and withdrawal symptoms. The first and most important one being alcohol. Alcohol is by far the most common because it is legal. It is also the most lethal. Acute intoxication of alcohol can kill you very easily. Withdrawal from alcohol can kill you. The way you screen someone to see if they are an alcoholic is using the CAGE questionnaire. You ask, have you attempted to cut down recently? Do you get angry when people ask you about your alcohol use? Do you feel guilty about drinking or the things you've done while drunk? And do you need an eye opener? That is, can you start the day without a glass of alcohol? What you need to be able to do for your exam is differentiate acute intoxication from withdrawal. And you need to know how to treat them both. The person who is acutely intoxicated with alcohol is the person that you couldn't stand at your college party. This is the guy who's got slurred speech and ataxic gait, which means also cerebellar dysfunction. Heel to shin fails. Finger to nose fails. Rapid alternating movements cannot be performed. And it is definitively diagnosed by a blood alcohol content greater than 0.08. That is 80 milligrams per deciliter. Intoxication does have a laboratory test. Withdrawal does not. A blood alcohol level greater than 0.08 is the legal limit at which people are no longer allowed to operate heavy machinery or vehicles. Recognize that until you get to about a blood alcohol content of 0.2, that is 200 milligrams per deciliter, does alcohol actually become dangerous. And, of course, the patient may actually just be found down. And so to treat the acute intoxication is generally just intravenous fluids and monitoring, making sure they don't aspirate. But if they are found down, you can give the Coma Cocktail. The Coma Cocktail is naloxone to reverse any opiates that are on board, thiamine, because alcoholics generally run out of thiamine, and then D50. D50 reverses hypoglycemia, which is also present in alcohol intoxication. You have to make sure you give the thiamine first because alcoholics don't have enough thiamine in their body as is, and the D50 won't do any good unless there's some thiamine. This is not very interesting, and this is sort of the bane of the emergency department. a drunk tank, taking care of a bunch of guys who are sleeping it off. But where it becomes very important for inpatient medicine is withdrawal symptoms, because the withdrawal pattern follows a very predictable course. The patient will begin with hypertension and tachycardia. Tachycardia is better than hypertension because most of these patients will also have hypertension. And so high blood pressure may simply be that they're not taking their meds. But tachycardia and hypertension in a patient who is getting clean of alcohol is the earliest sign of alcohol withdrawal. After tachycardia and hypertension, they're going to get diaphoretic. And very soon after, they'll get anxious. They'll feel like they're crawling in their skin and they need to get out. And right before they seize, they will get delirious. And if you spot someone going into alcohol withdrawal, you can save their life. Start them on a benzodiazepine taper, and then give them PRN benzos in order to control their symptoms. This may take 3 to 5 days to get them off the benzodiazepines, but they are clear of that initial withdrawal. Unless they start drinking again, they are clear of ever having withdrawal symptoms. There's a couple of things you need to worry about if you identify someone as an alcoholic. The first is Wernicke's encephalopathy. And Wernicke's is a reversible cerebellar dysfunction. And the way you treat Wernicke's is with high-dose thiamine, not just the same dose that's in a multivitamin, but high-dose thiamine. And then you can give D50. Be cautious with patients who you think are alcoholics, because if you give them D50 without giving them the high dose of thiamine, you're going to make the Wernicke's encephalopathy worse. The other thing that can develop in their brain is Korsakoff's. And Korsakoff's is irreversible. And it's confabulation. They're just making stuff up. They have holes in their brain, so they're just trying to fill it with whatever they make up. Essentially, this is an alcoholic-induced dementia, and the patient is going to be fully lucid, but just nothing they say makes sense, and nothing they say is true. This is irreversible and is a long-term consequence of alcohol. Finally is cirrhosis. Alcoholic cirrhosis is probably the most common cause of cirrhosis in our country. We have a whole lecture dedicated to cirrhosis and ascites in the GI lectures, but essentially what you need to look out for is ascites, varices, especially in the esophagus, which can cause GI bleed, and hepatic encephalopathy. The ultramental status of the delirium may actually just be liver failure and not alcohol withdrawal. And then, for anyone who actually is an alcoholic, you refer them to Alcoholics Anonymous. Group therapy is the thing that keeps these guys clean and sober. And this is true for any of the addiction diseases. Instead of Alcoholics Anonymous, you put whatever they're addicted to in front of it. Gambling, sex, narcotics, cocaine, whatever. Group therapy, Alcoholics Anonymous, is the thing that keeps them clean and sober. We do have a medication which can help called Antabuse. Antabuse is a disulfiram medication, such that if they take the pill and they drink, they'll get sick. They'll get nauseous, they'll vomit. But addicts are smart. If they are addicted to their drug, they'll realize if they just don't take the pill, they're able to drink. So generally this doesn't work, whereas group therapy in Alcoholics Anonymous is the only effective therapy we have. All right, so we talked a lot about alcohol. Now let's go over to a chart and review all the different acute intoxications and withdrawal signs and symptoms of regularly encountered drugs. This chart is also available in your notes and represents the first half of the drugs we're going to cover. Alcohol we talked in great detail, but to review, an acute intoxication is going to look like slurred speech, ataxic gait, impaired judgment and disinhibition, and patients are often tended to black out, that is, forget some of the night. Withdrawal symptoms are going to be hypertension, tachycardia, and it's going to progress on through delirium to seizures. The way you prevent those seizures from happening is a benzodiazepine taper. Of course, you're going to refer these patients to Alcoholics Anonymous and attempt antabuse. Antabuse generally doesn't work. Benzodiazepines are very similar to alcohol, except that they cause delirium in the elderly, and they are likely to cause respiratory depression and coma. Respiratory depression and coma don't usually happen because benzodiazepines are very safe. So you need a large dose of benzodiazepines or a combination with another depressant like alcohol in order to cause those problems. The way they are abused is actually as an amnesic. You see, benzodiazepines are the date rape drugs, where added to a girl's drink, she will then be disinhibited and not remember. Withdrawal symptoms are exactly the same for alcohol as for benzodiazepines, and so benzodiazepine withdrawal requires a benzodiazepine taper. If you have an overdose of benzodiazepines, you can use flumazenil. Flumazenil, however, does lower the seizure threshold and needs to be used with caution. Unless you are certain there is a benzodiazepine overdose, do not use flumazenil. Opiates, in their acute intoxication, can cause euphoria, but an overdose will look like pupil constriction, respiratory depression, and you may see track marks. Definitely look in between a user's toes to see if they're using the veins in between their toes, which they can hide. So no track marks will be found on their arms, but they might be found either on the penis or in the space between the toes. An acute intoxication, that is, an overdose, can be treated with naloxone. Naloxone, unlike flumazenil, completely reverses the opiate effects and has no side effect. Naloxone can be used freely. The only problem is if you use it in the hospital, that is, you are giving someone opiates and you think you gave them too much, giving them naloxone will prevent the effect of any opiate for about 12 hours. So if you're controlling pain, be careful how much you give. And if you give it too fast, you can induce significant nausea and vomiting. Withdrawal symptoms of opiates are yawning, lacrimation, sweating, itching, and all over body pain. You can treat the symptoms of withdrawal with methadone. Methadone takes the edge off. That is, it kills the cravings without getting the patient high. Cocaine is an upper. It's going to cause psychomotor agitation. They're going to be all active. Hypertension, tachycardia, they can even have violent psychosis. Their pupils will be dilated, and a side effect of cocaine intoxication is angina and hypertensive crisis. This is a vasoconstrictor which produces the hypertension and can also lead to the hypertensive crisis and angina. As they come off cocaine, they're going to go through depression. So they were all active and up, and now they're going to crash hard. Some patients may even complain of cocaine bugs, that is, little sensation of bugs crawling on their skin. Acute intoxication or overdose requires alpha blockade before beta blockade. This is theoretical, but since they're causing massive vasoconstriction, if you give beta blockade first, you'll have unopposed alpha-1 activity, and your hypertension will get worse. Finally, in this section is amphetamines. Amphetamines, like NMDA, cause dilated pupils and euphoric psychosis. However, acute intoxication may also produce overheating. They're going to get really hot, increase their heart rate. And because they have lost the sense of water balance, they may constantly drink water, leading to water intoxication. As you come off amphetamines, you're going to crash, just like with cocaine, go into a deep depression. Essentially, the only thing you need to do for people intoxicated or withdrawing from amphetamines is supportive care. Moving on to the next half, we're going to start with PCP. Intoxication with PCP can cause aggressive psychosis, and these guys are really angry, really strong, and barely feel anything. These are the guys who can be tased and not be dropped. These are the guys who can stand up while they're handcuffed to a hospital bed. They have impossible strength. The way you're going to get the answer right on the test is they're going to mention vertical and horizontal nystagmus. Actually, in withdrawal can also cause severe random violence, so you have to be very careful with people who have PCP on board. What you can do for them is, one, give them Haldol to subdue them. You may need to use pharmacologic restraints in addition to physical restraints. And a sort of fun pharmacological point that might get you a point on your test is to acidify the urine in order to enhance excretion. LSD is rarely seen. It causes hallucinations, flashbacks, and enhanced senses. Withdrawal may also cause flashbacks. Only requires supportive care. Marijuana, THC, the intoxicated state is going to show someone who's tired, with slowed reflexes. They might have conjunctival injection that looks like conjunctivitis, and they may have the munchies. That is, they want to go eat. Too much of it, it's really hard to overdose on marijuana, but you can get symptoms of paranoia. There are no symptoms of withdrawal, and essentially you don't need to treat it, either intoxication nor withdrawal. If you do, it's simply supportive. Barbiturates, they have a very low safety margin. They cause respiratory depression and coma. They cause the same effect as benzodiazepines, they're just more dangerous, and that's because they redistribute into fat. And so this is more useful not for your drug users, but for actually anesthesiologists. If you give barbiturates, they're short-acting. So for short cases, they're great. But if, unfortunately, the case goes a little bit longer and you have to give an extra dose, it may take a long time for those to wear off. Barbiturates in general are low yield. And I've put in nicotine here at the bottom. I don't really consider it a drug, but it's in some of the tables you'll see in other review materials. Essentially, there's no intoxication from nicotine. You might get a little jittery. People use it as a stimulant, and if you watch Thank You for Smoking, there's a risk for ventricular tachycardia if you have an overdose. But in order to overdose, you need super high doses of nicotine. You have to try very hard. And if you try to stop using nicotine, that is smoking cigarettes, you're going to have some cravings. And so to get them over those cravings, you can use the nicotine patch, the nicotine gum, the medication Wellbutrin, or now the medication Chantix. This information is found in your notes, and I highly recommend you simply memorize this table close to your test date. There isn't a whole lot of useful information in here for practice because it's what you're going to see on the USMLE vignettes that point you to a diagnosis, not necessarily what you're going to see in real life. We make these videos for free, and we need your help. Please donate, because without your donations, we can't make any more videos. Please donate.